Okay.
Good afternoon, everyone, and welcome to today's session number 4, the COVID-19 Best Practices in Nursing Homes. I am Susan Ryan. I am the Senior Director of the Greenhouse Project. And the Greenhouse Project, if you don't know, we are about comprehensive transformation to really eradicate institutional models. And we are grateful to be in partnership with Project ECHO to be able to offer this ECHO based model. I love the ECHO model, which really leverages technology so that we can share our best practices. We can really focus on some of the case-based, kind of those best practices where things are working so that we can monitor and manage our outcomes so that we will have that impact. Today's session I'm especially excited for. It's about leadership and what really matters most in a crisis. And so we've got two incredible speakers. I've had the privilege of talking to both of them. One will do a didactic that will really talk about how to build a culture of resilience, how to really think about what you need for your organization. And then secondly, we will hear kind of the new Jewish home, the CEO there, really talk about their experience from the perspective of a leader. Before we get started, though, I'm going to have my colleague Janet Wright just go over some logistics, a few housekeeping announcements. Janet?
Okay, my screen's not showing. Okay. So you will be in listen-only mode for the webinar or for the meeting. And my screen is not showing here. Let me try again to share the screen. Okay. Don't know where my other slides went. So you will be in listen-only mode. You can use the chat if you have any to make introductions, and also for any comments that you have or question and answer when we get to the question and answer portion of the program. Please share your webcam so that we can see who you are. We ask you to also put your name and organization in the chat box, and the webinar will be recorded. We will be sending out copies of the recordings to you along with the didactic and the other presentations after the webinar, probably tomorrow.
Thank you, Janet. I appreciate that.
I don't know where the other slides went.
That happens sometimes. So I'm going to introduce my colleague, Marla DeVries. And Marla, if you would just introduce yourself.
Hi, good afternoon, everyone. Marla DeVries from the Greenhouse Project. I'm the Director of Resource Development, and I will be jumping in and out of the session to help facilitate the questions. So I would just encourage you, as you are listening to our two fabulous presentations, if you will go ahead and utilize the chat for your questions as they come up, and I'll be checking those throughout the presentation. Thank you.
Thanks, Marla. So, Janet, are we ready to launch our first poll?
We can do that, yes.
It's so important to us to really get an understanding of where you live. And I think trying to understand geographically where you're calling in from. So take just a moment and let us know where you are calling in from. Geographically, where are you? Okay, let's stop our polling. Once again, we've got just a little more than half of you calling in from the Northeast, some from the Southwest, 10% of you from the Southeast, and about 16% from the Midwest, and even 10% of you are outside the US. So thank you everyone for being willing to jump on these calls, and I hope you will find them as insightful as I have found them in talking to our speakers today. I'm going to ask our subject matter experts to introduce themselves to the group. Dr. Power, would you introduce yourself to the group?
Hi, everybody. This is Alan Power. I'm a geriatrician from Rochester, New York, but I'm working now as an educator consultant and also been doing consulting with the Greenhouse Project in some of their education and support projects. Good to be here.
Thanks so much, Dr. Power. Eric Reguera from Jewish Home Family.
Hi, good afternoon, everybody. My name is Eric Reguera. I'm the Director of Nursing Services here at the Jewish Home Rockley, located in Bergen County, New Jersey. Thank you.
Great, thanks, Eric. Eric is our nurse clinician and really grateful for the input he brings. And Dr. Farber, if you would introduce yourself.
Sure, Susan. That's Jeff Farber. I'm here in New York City, the president and CEO at the New Jewish Home. And it's really a pleasure to see so many familiar faces looking around the Zoom table, and including yours, Susan. Thank you.
Likewise. Yeah, no, we're so excited to hear your story and grateful for your willingness to present today. And last but not least, I am really proud to introduce Dr. George Everly. I heard Dr. Everly speak on an echo session that I was listening to, and I thought, we've got to find him and we've got to bring him to our echo session. So Dr. Everly, it's my privilege to have you introduce yourself and then to share the didactic presentation that you've prepared for us.
Thank you, Susan. So George Everly, I'm here at Johns Hopkins in the School of Medicine and the Bloomberg School of Public Health. My area of expertise has been, for the last 40 years, trauma and disaster mental health. Have seen, followed various disasters, 39 countries, 6 continents. And what I've specialized in doing is building mental health responses to adverse events, but building it not from the traditional diagnostic and treatment point of view, but building it from a resilience point of view.
Great. Well, I will have you then go ahead and share your screen and take us into your presentation.
All right, so the title is where I'm going. Building an organizational culture of resilience. We use a two-pronged approach. I mentioned that my history has taken me all over the world, and I've seen disasters from famines, wars, tornadoes, floods. This is actually my 3rd pandemic, and if you count Ebola, it's kind of my 4th. One of the things that people find fascinating, however, is that the psychological trajectory of adverse events follow a predictable pattern. This is very important for us, because if the psychology is the same, if all adverse roads lead to Rome, in effect, that it allows us to better prepare, it allows us to know where we are at any given point in time, and it allows us to better allocate resources efficiently. That having been said, the 2 things that I've seen most effective in 30 years building mental health systems, mental health response, especially in healthcare agencies and organizations, hospitals, is this two-pronged approach where leadership combines with peer support. And I do disclose that I receive compensation in the forms of royalties and speakers' fees. So the Institute of Medicine published, I think, a very influential manual in 2013. It was basically building a ready and resilient workforce. In that document, it said that organizations most likely to survive and actually prosper in times of adversity possess a resilient culture. Former Assistant Surgeon General Brian Flynn noted, but the only way to change an organization is to change its culture. So what is a resilient culture? What is that thing that we have tried to build? By way of history, as evidence I'm not the smartest guy in the room, this was not originally my idea. The Chinese government came to me in preparation for the Beijing Olympics. I was actually holding a professorship at the University of Hong Kong and chaired a committee at the Hong Kong Hospital Authority. And they said, we are anticipating bad things coming our way. We need to prepare something different, something that in theory has never been done before. So we decided that we would try to build, as the slide says, an environment wherein human resilience, in other words, the ability to withstand or rebound from challenges and adversity, is not only fostered, but is within the core fabric of the culture itself. It should be a culture that is uplifting. It is a culture that is forward thinking. It is a culture that is supportive. The IOM report went on to suggest that resilient leadership practices may be the most efficient and effective way to change the culture. So here's a quick quiz for you. Pick the 4 most influential, effective leadership characteristics that predict not only crisis leadership effectiveness, but overall leadership effectiveness. Is it communications, economic management, ethics, integrity? Is it interorganizational relations, administrative skills, relations with oversight and collaborative groups, vision, a vision for the future, optimism, if you will, a policy of fairness and equity, or is it performance? What are the 4? So to answer this question, we have reviewed data over the last 17 years. And what we ultimately determined, it was 1, 3, 7, and 9, the 4 characteristics of resilient leadership, of overall effective leadership, but most importantly, crisis leadership, would be optimism, having a positive vision. No one wants to follow in times of adversity someone who doesn't believe there will be a tomorrow. Bold, decisive action. Have you ever worked for someone who couldn't make a decision? It sucks the life out of an organization. George Patton, arguably considered the greatest general of World War II, once said, "The only failure in leadership is the failure to lead." Integrity, ethical behavior, and open, honest communications. And it astounds me, actually, how frequently really well-educated individuals, experienced individuals, wait too long to communicate. They fail to communicate effectively in crisis. As Sun Tzu once said, writing perhaps 2,500 years ago, decisive action, be decisive. Vacillation saps the strength of any army. If action is necessary, make it swift, act boldly. No one benefits from protracted conflict or ambivalent leadership. Leaders must avoid paralysis by analysis. The moment of absolute certainty will never be upon you. The only failure in crisis leadership is the failure to act. I will say, as I've consulted with organizations and governments all over the globe, I have been stunned at 2 consistent mistakes that leaders make, especially in crisis. One is waiting for that moment of absolute certainty. What often happens is that moment never arrives, but the opportunity to effect a change positively does leave. Integrity, I stole this from the Academy Award-winning movie, The Gladiator. The main character, Roman General Maximus, had this penchant for saying, "What you do today will echo for eternity." If only I knew that when I was 16 years of age, but that's another seminar. And Warren Buffett, once the richest man in the world, said, in looking for people to hire, you look for 3 qualities: integrity, intelligence, and energy. And if they don't have the first, the other 2 will kill you. The second mistake, I said there were 2 fairly consistent mistakes that I saw people make in large organizations, really smart people doing really dumb things, if you will. One was waiting for that moment of absolute certainty. The other is from the communication aspect. They wait too long to communicate. There is no such thing, especially in this era of social media, There is no such thing as an information vacuum. If the leader is not communicating frequently and consistently, then someone else is. In effect, as a leader, you have abdicated your leadership, especially in this age of social media. What we do not want is to turn leadership over to the person in your organization who is the most distressed, has the largest Twitter feed and the fastest thumbs. And unfortunately, that is often what happens. From the communication standpoint, listen to the whispers so you can avoid the screams. Abraham Lincoln opened the White House every Tuesday, and anybody could walk off the street and sit down with the President of the United States. The security guard once said to the President, "Mr. President, you're wasting your time." He said, "On the contrary, this is the most valuable part of my day." 5 sins of crisis communications that we see. Communicating information as fact when it is in reality speculation. Delaying communications. Trying to please everyone. You can't. The failure to communicate. Basically, you're waiting too long. Lies, sadly, and half-truths. And some people will say, and I think they are good people, look, I didn't lie, I just didn't tell the total truth. And my response is, if your intention was to deceive, then it was a lie. Once you have lost trust, it's very hard to regain it. We know organizations that have this elusive issue of trust are remarkable places to work. So that's leadership, 30,000-foot view, 7 or 8 minutes. The other thing that we do, and it's the other prong of our 2-prong approach, is psychological first aid. It actually is not an independent silo, however. The prongs are joined. For we teach every frontline manager psychological first aid. Have you ever noticed as a manager that sometimes folks who work for you come not only with professional questions, but also personal questions? The notion that one's personal life and professional life are independent silos is an illusion. We no longer entertain the idea of work-life balance. That is an illusion. I think it always was an illusion. If not, it is certainly something that I think we have left behind pre-COVID. We now deal with what I will call work-life integration. And if you're not sure what that is, ask someone whose children are going back to school virtually, and they are being asked not only to work from home, but to educate their children. So we teach managers, frontline managers, if you want to change an organization, absolutely get buy-in from the C-suite, but organizational cultures are cultivated at the frontline manager. So when I've gone into organizations, rather than train everyone in human resilience and the like, we simply train frontline managers. They are the people that make the difference. So we use various tools, but psychological first aid is the basic operational tool. And within each organization, we construct what, for lack of a better term, we shall call a peer support program. I would argue to you the emerging standard of psychological care in healthcare and law enforcement industries professions is peer support. And this is what we do at Johns Hopkins Medicine. Our frontline supervisors are now mandated to take leadership training, and we have also stood up a peer support program where the interventionists are trained in psychological first aid. PFA, psychological first aid, is not diagnosis, it's not treatment. We can train physicians, nurses, security personnel, technicians at any level. PFA has been recommended by the World Health, by United Nations, American Psychiatric, American Psychological, and the list goes on. What is it? Notice, please, in this definition, the absence, conspicuous absence of diagnosis and treatment. It is a supportive and compassionate presence where we also teach people how to stabilize and mitigate acute distress, and perhaps most importantly, how to recognize when the person in front of you needs some higher level of care. This was prescient, 1965. A little help rationally directed and purposefully focused at a strategic time is more effective than extensive help given at a period of less emotional accessibility. And this was borne out many years later, 50 years later, when a group, I was not part of it, did the most comprehensive mental health assessments post 9/11, and they found acute phase post-disaster workplace-based crisis intervention, psychological first aid, if you will, was found to be superior to multi-session counseling. How long does this last? How long can these interventions last? Perhaps a lifetime. We've documented at least 20 years. At first you'd say, oh, that doesn't sound right, but wait a minute. Come into a person's life at that essential moment and redirect them from a going off the cliff, going off the rails, tragic decision, and put them back on the rails to perhaps a far more optimistic future. And indeed, the future can change. The model we use at Johns Hopkins, here's a surprise, drum roll, sitting down, ready for this, we use the Johns Hopkins model. Go figure. As far as I know, it's the only evidence-based model of psychological first aid. We have found that it is not only clinically effective, we've applied it at the community level and have found change is effective at the community as well. What we've done at Hopkins and we advocate is not just peer support teams using psychological first aid, but rather a wide array, a multi-tactical intervention system. We use at Hopkins a complete continuum of care, which is unfortunately beyond the scope of this talk, but we have written about it elsewhere. How do we know it works? If you take a look at the numbers in parentheses, you'll see effect sizes for workplace-based multi-tactical intervention systems, and anything that is 0.5, 6, or 7 is considered significant. Anything 0.7, 0.8 above is considered large. If you're not into statistics, let me simply say this. If you have a 0.8, 0.9 coefficient, it is roughly the difference between someone who is 5 feet tall and someone who is 7 feet tall. So it's quite striking. We even did a cost analysis for the hospital and found that the Hopkins Hospital could save almost $2 million a year on attrition, on sick days, on poor performance using a peer support system. Now I'm out of breath and I'm out of time.
No, well, I'm sure we'll have questions for you. So Dr. Everly, that I always learn something and I'm taking notes as you're talking once again. If you've got questions for Dr. Everly, please put them in the chat box. And in just a moment, I'll have Marla ask some of those questions. But I wanted to open it up to Dr. Power, to Eric, and to Dr. Farber. And please feel free if you've got a question. Go ahead, Al.
Yeah, thanks, Dr. Everly, for a great talk. And I'm sure that Eric and Jeff will have more to say because they've been more in the face of the crisis over the last several months than I have. But I really appreciated your talk. I loved your comment about the fact that there is no information vacuum, and the people that are afraid of sharing information often shoot themselves in the foot. The thing that I find a struggle, and I don't know what the answer is, but having worked in long-term care and around long-term care for decades, is that it is such a reactive system. It's a system where we're always waiting for a crisis and then reacting, or the regulators are changing things up, or we get a deficiency and then we have to come up with a plan of correction, and to turn that around to build the infrastructure for a resilient system seems like a real challenge, I imagine, for a lot of people who are working with staffing and living wages and all that. And so I'm just curious your thoughts about how does long-term care begin to get their heads around being more proactive about resilience in such a reactive system that we have going right now.
So it's a fantastic question. Thank you for asking it, sir. So we have done our due diligence in terms of reviewing resilience systems at the workplace. And the reviews that are out there reach a sad conclusion, and that is there's really no evidence that resilience programs at the workplace work. So what's wrong? So when we did that analysis, we were also faced with the fact that we knew there was this thing called human resilience. I've studied it for decades. I know it's there. I can recognize it when I see it, whether it's an organization or a human being. It to borrow a phrase, it ain't rocket science. So why is it that we fail to effectively institute it on the organizational level? So at my institution, we question everything, and I think that's probably the case at most academic institutions. So we said there's something wrong with this formulation of resilience. What we ultimately discovered was human resilience was really two things, inextricably intertwined. But one had to pay a certain due diligence to each one. One aspect we called resistance. And we published this paper actually in 2006. We created a resilience continuum. So resistance is developing work with me here a little bit, a psychological immunity, whether it's for an individual or for an organization. We absolutely know this exists. We've measured it, we've seen it empirically. But then there's the other part, which is no vaccination, no immunity is always complete. So you get a flu shot, you still may get the flu, but hopefully it won't be as intense. Hence, we need another aspect to that continuum, which is resilience. Resilience in the English language, I use the Oxford denotation, which is the ability to bounce back. So now you put the two together. We formulate a resistance strategy, we integrate it with a resilience strategy. We find that leadership is your single best contribution to the variance for resistance, and peer support, social support, interpersonal support is your single best contributor to the variance for resilience. I could go on and on and on, but I'm trying to keep it short.
That's beautifully said. So, Jeff, I'm going to go to you because you're first in my Hollywood squares. So any questions for Dr. Everly?
No, I'm going to wait till maybe a little bit later Q&A after I speak as well for some things that might come up.
Okay,
Yeah.
Excellent. Eric, how about you?
Yes, again, based on our experience during the height of the pandemic and what Dr. Everly said, leadership has a great major role in resiliency. During the height of the pandemic and until the present, until now, the role of the executive leaders, more so our CEO, Carol Silver-Elliott, has a great influence, in all of us, especially during the height of the pandemic. One perfect example is during the morning huddles. Whenever you're in that morning huddle with Carol and all of the rest of the executive leaders, just giving the words of encouragement, gives you that confidence that we can go through this together as a team. Those words, being about positive, being optimistic vision, that gives you that standard, we will follow it, we will do this, and we can get through this together as a team. So those words alone during that huddle, it's so much important, not only for me, for the staff members and the whole entire building. Those kind words, it comes a long way. It did, and look at we now, and we're doing our best to make sure that pushing that envelope, making sure what's best for the elders and for the staff.
Susan, if I can comment, I'd like to
Sure.
follow what Eric is saying. So in the social sciences, the most empirically pristine and influential research has come out of Stanford. Dr. Albert Bandura has published on this concept called self-efficacy and human agency. It has relevance not only for leaders, it has relevance for nursing home and residents, for staff at every level. It is a rather profound predictor of human resilience. But what surprisingly has been shown to be a little bit more powerful is something called collective agency. And collective agency is exactly what Eric just commented on. The belief of leadership that they can make a difference, that they can go out every morning and do something positively, do something anything that makes a difference. In the this sounds almost counterintuitive. In the absence of collective agency, personal agency is powerfully reduced in terms of its impact.
Wow. Well, that's powerful. And having kind of walked with Eric and Carol virtually anyway through their experience and what you just had to say, that's so true. I could really see that. So thank you both for that. Marla, I'm going to ask for a couple questions maybe that have come through the chat.
Sure, I have some through the chat and some that came in earlier through registration. So first one is, are there any daily practical practices that can help grow and fortify resilience?
So we advocate, again, from the resilience standpoint, another two-pronged approach, not to be confused with the other two-pronged approach. But individuals really do need to take care of themselves. And there is a science to that. When I do work with military and law enforcement and fire suppression, we call it psychological body armor. The concept resonates with them because they often wear physical body armor. They understand that concept. So the notion that you can protect the mind, if you will, is novel, intriguing perhaps. So we actually have a program to teach psychological body armor. But I think something else, and I'll go back to Eric's comments, that morning huddle can be really, really important on a daily basis. When I was working with the New York City Police post 9/11, my query, I've never been in law enforcement, but my query was, is there any time that we can get every sworn officer together where basically everybody comes together? And they say, well, it's called roll call. Okay, great. That roll call became Eric's huddle, if that makes sense. So at shift change, doesn't matter. Police run 24/7, hospitals run 24/7, nursing home runs 24/7. But there's always a shift change. There's always an opportunity for a huddle. And within that huddle, there's always an opportunity to foster collective agency.
That's great.
So this is sort of a related question then, perhaps, because you mentioned that peer support is an important aspect of psychological first aid. So anything else on what does that really look like, and how does peer support really operate?
So peer support generally operates by taking individuals at that organization, all levels of the organization, regardless of what their professional training is. So again, it could be security, it could be nutrition staff, it could be physicians, nurses, doesn't matter. And we train them in psychological first aid. We set up a program that runs 24/7. There are a lot of logistical ways and variations to do that. I won't get into that, but basically the program runs 24/7, and individuals who are finding themselves distressed either with occupational, organizational, or personal issues have access to this peer support team. So we have, I actually oversee 3 national and one international peer support team for large organizations. So we can cover a rather large organization with a rather small group. But again, they're just trained in first aid. It's basically the concept, psychological first aid.
So here's another question. Are there ways to help bring resiliency to family members and to residents that are struggling with some governmental restrictions? So they're not part of the peer group, the staff. Are there ways to bring some of these concepts to them?
Almost every peer support program I've stood up, I've encouraged them to extend it to family members as well. So I work and have worked for the last 20 years for a very large federal law enforcement agency. The peer support team actually consists of family members as well and extends to family members.
Great. So one final one, and then I'll turn it back to you, Susan. So if an organization is interested in doing more with psychological first aid, what would be a first step that you would recommend?
Do your due diligence. Read what is out there. You know, my email's there. Shoot me an email if you have a question. Happy to respond.
Great, thank you.
Well, that was awesome and a perfect setup for you, Dr. Farber, to share your story and kind of out there on the front lines and kind of what you learned and your experience. So Dr. Jeff Farber, tell us what leadership really means in a crisis.
You bet, Susan. First, tell me if you can see my screen, and is it the...
It's not it. There you go. Now it's in
All right.
presentation. You're good.
Thank you. So listen, Dr. Everly answered the question. So what matters most in a crisis, you now know from the expert. And what I'm going to do is share a story in about as many minutes as I have your slides to sort of help me speak to the major points about what it's been like leading a nonprofit, or as I prefer to say, for community benefit healthcare system for older adults for the last 171 days through what I think all agree has been a truly unprecedented crisis. So I'll get through and then very much look forward to the Q&A. Just briefly, so folks know who we are, where we are. We're a healthcare system founded 1848. We've been around a long time in New York City, have deep roots, and we care for well over 8,000 people a year. And we do that through, you know, a portfolio of services that are similar to many on the line. So I won't bother getting into, but we have 2 large-scale nursing facilities with over 800 beds combined. And what I'll share with you now is our experience primarily related to the nursing homes. 171 days ago, we had our first resident diagnosed. That was Saturday, March 14th, and I've been, counting ever since. Very quickly, you know, no secrets, you guys know, New York became, in New York City in particular, the global epicenter of the pandemic. And what I realized very early on was that we weren't just dealing with this novel coronavirus, about which much was unknown at the time, but we were dealing with this equally devastating coexisting pandemic, as I came to understand it, of really fear and anxiety and uncertainty, which was crippling and harmful in as many ways as the virus itself. Adding to that, I came to realize a little bit later, sort of a third front, if you will, in this battle, which was totally avoidable and unfortunate, which was the media and the elected officials, you know, outright blaming, you know, scapegoating, vilification of the industry, looking for heads to hang, to say, hey, you know, why are so many old people dying in nursing homes? It must be because, you know, you're all vacationing on the beach in Florida, because, you know, no visitors are allowed, and so you don't have to really bother doing what you're supposed to do, or you have an immunity, you know, from COVID-related litigation, malpractice, so therefore you don't care. And it's just, you know, again, as equally challenging and demoralizing as the pandemic and the uncertainty associated with around it. A couple other sort of overall highlights to give you a sense of what we've been through here, the 2,000 plus Jewish home family, I like to call them our employees, you know, is call outs. People were sick themselves, people were scared. 7 times the normal rate, you know, 3 times a day, 7 days a week was a real struggle. And we managed to secure everything that we needed, including staffing and personal protective equipment and on-site testing with, you know, virtually absent government support. And in fact, I'd say, you know, an outright hostile government and other elected officials, both state and federal, you know, in terms of this pandemic. Overall, when you look at some numbers, you know, we've cared for well over 500 people over the past 5 months with this illness, including over 100 that we admitted from our hospital partners, not because we're mandated to or told to, because that's what we do. And we have those capabilities, and it's our responsibility to play the role that we can, commensurate with our capabilities in this pandemic. And we've got a ray of light here, a sunshine in the, I didn't show a picture on the slide set, but of a rising sun in the lobby window facing the street in Manhattan, with each ray of light representing one of the 398 people that we helped shepherd through this illness and recovered. And we mourn deeply for the tragic loss of 113 older adults who died in our care. So I think to complement what George spoke about, from an academic perspective, I'll just share a few highlights of what I, sort of realized and or learned or tried to do leading this organization through this challenging time. The first thing I felt it was really important to simplify what's going on. The marching orders for the team need to be clear, and there can't be, as you mentioned, ambiguity or vacuums, both in communication and in what we do and why we do it. And you got to start with yourself first. So I have a whiteboard that I'm looking at right now over my desk in my office, and I cleaned up all the garbage that was on there, and I wrote down 3 things, and that's what I did for the bulk of the time up until relatively recently, when I now have the fortunate ability to think about non-crisis related organizational priorities. Number 1 is the staff morale and making sure that I'm out there, visible, thinking of every way possible to appreciate, value, and recognize the staff, especially in light of the vilification and blaming of the industry and the staff feeling underappreciated and undersupported in general, especially compared to some other healthcare workers in different parts of our ecosystem. And 2 was, of course, the clinical care model. As I said, we didn't try and close our doors. We didn't try and send everybody to the hospital for care. We did the exact opposite. We were part of longstanding, deep, productive relationships with our hospital partners, and fully capable and needed to, commensurate with our organizational values, take care of people. So making sure that we've got the best quality care, doing everything we can to minimize spread was priority number 2. And then 3 was, making sure that I, as CEO, am out there reaching out at the highest levels to supporters, to donors, to foundations, endowments, and government to get the support that we sorely need. And I already told you a little bit about the government letdown, but many people in the community outpouring and people just stopping by with food, with gifts, with handmade, PPE, with PPE that people bought themselves to drop off, was incredibly nourishing and helpful for the staff to know that they're not alone. So on the staff morale front, as Dr. Everly said, it's about telling stories, and I think a big role for the leader in a time of crisis like this is to be that chief storyteller. And somewhere relatively early on, I just came across a way of thinking that is arguably not profound in any way, shape, or form, but it made things very simple. And it was something that I could use in communicating at our daily, 7-day-a-week task force meeting to make sure that I'm encouraging and motivating the team, which is, look, well, we don't know how long this is going to last, right? I don't know how painful and how dark and how long this tunnel will be. I know without a shadow of a doubt that it's going to end at some point, right? We're going to make it through on the other side. And therefore, each day when we wrap up that day or we have our daily meeting or whatever marker you want, no matter how terrible and painful that day was, it means we're one day closer to making it through. And so that each day we now can view as a small victory, as a small win in this ongoing battle. And that really helped me personally. I shared it with colleagues, with the team, with their teams, and it became a healthy way to sort of have a mindset that, even though this is really unbearably challenging, we're making progress towards an end goal that we all share confidence in. A lot of my job was to make sure I continually shared that confidence that we're going to make it through. And then the communications, as Dr. Everly mentioned, we tried to do always, so, up on the floor, speaking with staff all the time, different shifts, weekends, weekly writings, inspirational videos that I would take just using my iPhone and sending them out broadly using our, text messaging and emails to staff, letters called Dear Colleagues to highlight stories and counter the negative narrative that's been out there in the press. And then the other thing I think early on that was helpful was thinking about crisis governance. The leader has to really make things simple, as I said, deputize a leader, which I did, and chose my medical director, Ruth Spinner, who's done a remarkable job over the past 171 days to lead our interdisciplinary task force, and then make it real clear on what, the line of authority is and who gets to make what kind of decisions and what needs to come to me. And just doing that in a crisis, I think, is extremely helpful, because otherwise, again, that uncertainty, that ambiguity, that lack of clarity can become, in people's heads, it's the worst case story. And then here's a little bit of what we've done over the past 5 months. There was a question earlier about practices you can do on a daily basis, and these may work for some, they may not, but what I found very helpful as I think back to what helped us, make it through and have this positive mindset is, first, really having the understanding that this is not going to be over quickly, that this isn't a sprint, and you got to manage your energy for the long haul. It's not like doing a 24-hour shift as an intern in the hospital and, I'm going to make it through. When it's over, I'm going to rest. It's long. And so preparing mentally and physically for the marathon is really helpful. I think too, it's that, easier said than done to be present and listen, that there's so much fear and anxiety and mistrust, because of conflicting guidelines and things that keep changing. New York State and federal guidelines don't always sync up together. Guidance around PPE and the appropriate use, what to do if you get exposed, what changes a lot throughout the crisis, and that creates a lot of mistrust. And so, I think it's the right thing to do to put yourself out there as the leader, to be on the receiving end of some tough, conversation, or really sort of one-sided often venting. And then it's important to practice that self-care, and make sure that you have a safe outlet so that you can talk outside of the workplace, with others that are sharing a similar experience. 3 was interesting, and the story maybe later in the Q&A, but you see a lot about who truly is a hero and decides to run towards the crisis as opposed to folks trying to avoid it. And instead of trying to do something about it as a leader during a crisis and getting distracted, I decided, just take note of that data point, deal with it later, right? And that's been very helpful. Recognizing how emotional and how scared people are helps you to remind yourself to always assume positive intent, and to not just take A and B and say, well, that must mean that that person didn't care, or that they're not doing something, or out of sight or out of mind. That's not helpful, and often just not true. The uncomfortableness of heightened emotions was something that was surprising. I started with like these chills throughout the day, and I didn't know what they were. And I'm in the room with patients with COVID to show the team that it's okay and wearing. So I said, I better get tested. Now, that was 15 tests ago, right? I've been tested now 15 times, including today, because of our state requirements for frequency. And it was just a sign of heightened emotions, and that's okay. I think it's okay for the leader, in my opinion, no data behind this one, but just experience, to show your vulnerability. You're human, and you feel what people are feeling. I think what's not okay is showing your fears and your doubts. And so I've worked really hard to keep that out, to always be positive that we're going to get through this, that we can handle all the things and difficulties that are coming, and find someplace else, and some others to confide in, which I did. And I know everybody must in order to make it through. And then I think, it's really important to be kind to yourself. We often are our own harshest critics. And so on a daily basis too, I think it's helpful to say, well, wait a minute, why am I feeling so, overwhelmed or burdened or burnt out? And give yourself a break. So at some point I realized this probably, a bit too late, I need a break from going to the floors. I can't handle it. It's been too long, too many days in a row, being on the receiving end of so much negative energy, so much fear, so much uncertainty, anxiety, questioning and mistrust. I need to not go on the floors. I could still come in and I could do other things, and it helped. It helped dramatically. I just needed a break, and I had to give myself that break the way I would expect and want others to. And then some of these sanity promoting behaviors are really worked for me. And again, they may or may not resonate with you, or some may, but I share them. Scheduling physical activity, exercise, even if it's just, getting out and walking daily. We're blessed here in Manhattan to have Central Park really close by. And so, I made it a practice every day I would go out and get some, nature, right? To combat that nature deficit disorder, to breathe fresher air, to walk and clear my head. And I would encourage the team to do the same. At home at the dinner table, I didn't want to bring this. So I would, ask everybody around the table what went well today. And even when things are horrific and you have people dying all around and you have no place to put dead bodies and the funeral homes are overwhelmed and, your morgue is overfilled, there are things that went well if you force yourself to think about it. And I would share those good things and ask everybody else around the table to do the same, which really helps. Dr. Everly talked about, the impact of psychological first aid and things on alcohol, and I think absolutely true. It took a lot of effort, to be honest, to avoid, going home and pouring a glass of scotch and maybe a second and a third, and just, because that's too easy to do. And again, having that peer and that support groups to help you other ways is important. And as you can see here, dressing in professional attire, keeping that routine, coming into work every day, I found really helpful. It's something that's not changing. right? In the light of everything else that is changing. And for me, it helped to anchor me, and sort of, this isn't so, unworldly. There's terrible challenges, and, there's things that are the same. And lastly here, this is something I started doing actually with the help of an executive coach with who I've worked on and off for a number of years, so I find very helpful, is, visual imagery. And I would take a break when things got tough and recognizing yourself, what those physical manifestations are. But then I would think of my mountain house, which I don't own or have, but, one day in my head I do. And I picture myself, coming up on the gravel driveway and, walking up the steps to the porch, and I can feel, the creaking under my feet. I can see and feel the cool air and the sunset. And I visualize, this whole experience up in the mountains, which is where my, favorite place to be is. And, within a minute, I feel good, heart rate is calm and head is clear, and it works. And this is something I shared, with my team as well. And that takes me to sort of what I think a leader can do to help the team manage their energy throughout something like what we've been experiencing. You mentioned a lot about Dr. Everly, and our head of human resources, Audrey Wathen, has done a tremendous job creating peer-to-peer support groups, group virtual gatherings, mindfulness groups led, just be scrappy, hey, who does this? Oh, we have somebody actually amongst the 2,000 plus employees who, teaches mindfulness to others, and she's willing to, do this a couple days a week, 6 o'clock, whoever wants can join via Zoom, and people did, and it really helps without, having to go outside, since you're spending so much time in the organization, and with people that you can build, meaningful relationships with. Told you about the daily dose. I would sort of take advantage of the doctor hat and tell folks on my team, to get outdoors, 15 minutes, think of it like a medication on a prescription pad. The Zoom meetings, we translated, just instead of weekly meetings where you have all these agendas and things to do, it became a check-in and just go around the virtual room of how you doing, no formal agenda, just how's everything going? How's your family? And let's touch base and really help each other out, which was I found to be very helpful. And, in terms of making tough decisions all the time, Dr. Everly talked about being decisive and not wavering in the face of a crisis. I found the best way to do that is by always just going back to your mission, vision, and values. And when you have a decision, you say, well, report it, or family outreach. Who do we say? What do we say? Well, what are our values, right? We're increasing knowledge, right? We're respecting one another. We're extending welcome and embracing diversity for all. So that's what we're going to do, right? And does this help advance our mission of eradicating ageism? Does it help to bridge, gaps? And then that's how you make your decisions. And it becomes quite easy to make decisions that otherwise might be difficult, and you can make them more quickly. It's a good opportunity to tap in everybody, including myself, the meaning and purpose in the work, which at the end of the day is the whole reason that we're here, and validate people. And it's okay, to feel lonely, to feel hopeless, which is why you rely on each other then, to vent and to get those feelings out. You mentioned the inspiration, of leaders like Carol, on the call too. I made a point every day, looking for inspirational words to close up every meeting. It's not easy after like 60, 70 days, straight, and you're kind of find things. And it just became something I did. And people, feedback was that it was really helpful. They look forward to it. And those inspirational quotes mean different things when you're in the moment. I think it relates to the research Dr. Everly pointed out around when things are really heightened and when you're in a crisis and an acute situation. A very small amount of intervention can have a great impact as opposed to prolonged, therapy or treatments at times when you're not so emotionally stressed. So we take advantage of that. And as I said, those positive stories, people flying across the country to come back and help, former employees who left and for purposes of family and said, I'm seeing what's happening in New York, and I love the Jewish home and I care about old people. I'm going to get on a plane when nobody is flying. I'm going to fly there, put on my scrubs, do the orientation and start working, 12-hour shifts. It was amazing. These kind of stories were amazing. And then I really think it's about people have varying abilities to do this, your choice and how you view things. And there are positives in this. I mean, it is a great opportunity and has been to build and strengthen these professional relationships. I've gotten to know Sandra Mundy, my administrator here in Manhattan, extremely talented in a way I never would have gotten to know her if we hadn't had this crisis, if we hadn't been together in the trenches if we haven't spent so much time together in such challenging situations. And that's only going to help us, right, in the organization as we come out the other side. The laser focus I told you about was a kind of a delight. You know, the other issues that may not enjoy as much throughout the day, they drop off because you're laser focused on, you know, a very small set of goals. Talk to you about the view of each passing day, you know, and you learn from everything. And there's nothing like learning from a crisis and a fire. You know, that's where leaders are forged, and you got to go through it. You can't just, you know, read about it. You got to experience it. The mundane board meetings are on hold. I got into trouble commuting. For anybody, you know, 50% of you in the Northeast, you're probably related, but I drive from New Jersey into New York City, and there's nobody, you know, on the bridge at all, and it's a delight. And I would start testing myself how fast I could make it door to door. And, you know, I got down to 21 minutes, which, by the way, is remarkable for a 14-mile commute from the suburbs into the city. But then I started getting tickets in the mail from the cameras on Broadway, because it was a speed camera, you know, and it was so unfair because they said, you know, this is a school zone, so we send automatic tickets, you know, for speeding in a school zone. I said, there's no school, right? There's nobody anywhere. Like, give me a break. But after I got a couple of those, I stopped doing that. But it was still enjoyable to have the commute. We had donations at lots of things. One of them was somebody had a connection with the Kind Bar, you know, company, and we ended up with 15,000 Kind Bars. So I would eat, you know, all sorts of healthy snacks whenever I wanted for a long period of time. I told you about the walks in Central Park, which before the crisis, you know, more days than not, I wouldn't do. And it wasn't because I couldn't, it was because I would not prioritize that and let other things take its place in meetings and this and that. And I really like that. And, you know, again, keeping in mind that this too shall pass. So to wrap up, you know, if I had a redo, and Susan was asking me to think in one of our last conversations about that, I certainly would have, you know, and this goes really exactly to what Dr. Everly was saying around communication. As much as I think we did, I would have done more. And I would have spent more time and energy doing that even earlier on. I also would have thought and given myself a little bit more slack in managing my own energy more effectively. I gave you that example about taking a break, you know, from walking on the floors. I probably should have taken a break a week or two before I did. And I probably would have been much better positioned, you know, to continue to lead after that for this marathon, instead of waiting so long and finally realizing that that was what was needed. Always assuming positive intent, maybe easy for many of you on the line, but honestly, it's something as I become more self-aware of myself and as a leader, is not that easy. It's not always the default. And when I see people, you know, or when I don't see people, because a lot of the staff that was not on the front lines, you know, with us as the frontline healthcare folks delivering care, they're working remotely. You know, it's too easy for me to say, well, I'm not hearing from them, not seeing them. I don't know what you're doing. You're probably not doing anything. And then when I ask you to, you know, come in, this leads to the last bullet. You know, it's really important not to take things personally. So there was a time when I reached out and I tried to, you know, rally my non-clinical, my corporate team who were working remotely to come and help on the weekends because there was a big need to do a bunch of stuff. And a lot of people didn't come. And, you know, it was really disappointing. Helped me think about more deeply all of the emotions, all the fear, all the anxiety, people's stories. And, you know, again, next time around, or wave 2, which I know is coming, though I'm confident it won't be anywhere near as terrible for us here in New York as it was the first time around, you know, is not to take that personally. It's to assume positive intent and recognize that people are in different places emotionally and with beliefs, and, you know, accept it as a data point and move on. So, you know, and it's funny, I mean, Dr. Everly and I could have synced up our slides and done them together, and we didn't, believe me. We both worked on our sets and shared them, and they just fit really well. This is an example of one of the, you know, earlier quotes I would share with the team from Winston Churchill on resiliency. And I think it speaks to exactly the definition that we heard, which is, you know, we're going to go forward together. The road upwards is stony. There are upon our journey dark and dangerous valleys through which we have to make and fight our way. But it is sure and certain that if we persevere, and we shall persevere, we shall overcome through these dark and dangerous valleys into a sunlight broader and more genial and more lasting than humankind has ever known. So that's my brief synopsis of 171 days of what I would otherwise call torture. But let me unshare my screen. And,
Jeff, thank you so much. That was phenomenal. And just so everybody knows, I did an extended interview with Jeff for our podcast, Elevate Elder Care, and that will be released in a few weeks. So you'll want to hear kind of the expanded version of his 171 days, although it wasn't quite that many then. So I'm going to ask Dr. Everly, Dr. Power, and Eric, if you have any questions for Jeff. I want to open it up to the three of you first, or any comments, and then I'll turn it to Marla.
Just a quick comment what Dr. Farber said, you know, and what his presentation, great presentation, Dr. Farber, and I totally empathize what you've been through. You know, we're practically neighbors. I mean, when we experienced this, you know, it happened to you in mid-March, it happened to us in late March, so pretty much we're on the same cluster. It was really tough. It was really challenging. All happens at once, a lot of confusion, a lot of hysteria, a lot of fear and anxiety. You know, elders are getting sick, staff are getting sick at the same time. I mean, there's that fear and trauma to us. But again, thanks to what you do, Dr. Farber, you know, the leaders in our building, Carl Elliott, and you as well, with your leadership, you know, I mean, we went through this together as a team, and we know it's not easy. I mean, especially on the beginning stages with the changes of the guidance from the DOH and the federal guidelines. It keep changing beneath our eyes, and there's this mass confusion and uncertainty. But with the leadership, that's the big key. That's the big role in order to go to that path. You know, I've always been thinking, you know, we always need to be a service of the staff and elders, but in return, you know, that's our service to ourselves as well. So again, thank you, Dr. Farber.
Thank you, Eric. Words are great, and we do share mission, values, geography,
Yes.
and
Yeah.
you know, you guys are wonderful too. I have family that you take care of, and I have all the
Yeah.
utmost confidence.
Yeah.
So thank you.
Thank you.
Dr. Power, anything
Just a
from you?
wonderful presentation. Thanks so much. You know, to really take one of Dr. Everly's salient points and just make it really granular and down to earth and give those examples. You know, the most important thing that for other people like Dr. Murray Bowen talk about this, the first thing in calming the system is self-awareness, looking inward. And as the old novel House of God, you say, first procedure in a cardiac arrest is take your own pulse. And you did that, and you gave yourself some marching orders, and then you were self-aware. And I really appreciate that. A lot more I could say, but I know there's lots of questions, so I'm going to step back. And thanks again, both of you, for your great presentations.
Thank you, Al.
I just wanted to thank you, Jeff. What a phenomenal presentation. It's very clear to me that your staff and your residents are in good hands.
Thank you, George. Appreciate it.
Thanks so much for that. And Marla, I'm going to have you just go to the questions from those that have been listening.
Sure, and I will echo, there have been a lot of great comments in the chat for both presentations. So one question is your organization unionized? And if so, what challenges or how did that have an impact during the last, did you say 171 days? How did that have an impact?
Yeah, so it's a great question. The answer is yes. We actually work with 4 different unions. So the vast majority of our 2,200 or so employees are unionized, and it absolutely added another level of challenge. You know, there was always, in my view, somewhat, you know, counterproductive and dysfunctional relationships between, you know, people, our employees, and who are, you know, union members, the union delegates, you know, who are supposed to be in a role of representing and advocating for, and then leadership. And, you know, in a time of crisis, and look, I see this as a geriatrician, right, to take care of old people, and I've been, you know, primarily hospital-based for my 20 years, right, as a doctor. People are not at their best, right, when they're stressed and in a crisis, and people often, you know, knee-jerk reaction to their comfort zone. And in general, the union, you know, relationship is one about, not specifically here in Manhattan, I just mean in general, is confrontational. You know, the union exists and justifies their existence through, you know, the language that is very similar to what we hear now, battle and fights and demands, and, you know, and so there were certainly, you know, added stress and challenges to communications, I'd say, because of the union presence. At the same time, you know, leverage that by deepening and developing those relationships with a handful of leaders, right, amongst the union, to bring them in and have daily communication during the height of this crisis with them, literally daily with the delegates, to tell them what's going on, because we needed their help to also, engage the rest of their fellow members. It became really hard. And more time I could share, this whole issue around hero pay, hazard pay, battle pay. All of us in our geography, had a hard time with this. And it's an interesting, I think, individual sort of story about, dynamics and power and relationships, but that's too much for a simple answer. But yeah, we are, and it's a challenge.
So here's a related question. How do you support the negative Nancys who feed off everything that's going wrong? So what tips would you offer?
Yeah, they'll be there and they'll continue to be there. And, that's a marathon too. You can't just say, okay, let's meet and tell me everything that's going on. And let me be, empathetic, give you a sympathetic ear and let's listen and let me explain. No, that's not actually true. We do have all this and this is why we do that. And this is not how the virus spreads. Like, this is how it spreads. You have to know that it's not going to work. You have to keep at it, repeated interactions. And honestly, it's about building relationships that matter, right? So when I'm there, I often made efforts to be around, as Dr. Everly said, he talked about the police or the military and roll call, and well, we have shift changes and that's when everybody's coming and going and you're just there thanking people. That kind of person will pull you aside and give you an earful, and that's okay, right? You listen, you have an open mind, and sometimes swallow your words, just listen instead of speak back, and it often makes progress, right, towards making that better. And the other thing is it's hard for people to do that when they see you with them doing the things that they're complaining about, right? So when you're there on the ground, and I hope people are okay, you're moving a cadaver, a dead body, from a room down to the morgue, you're wearing the same gown and the gloves that you're asking the team to wear that's safe, and they know they see you. It becomes hard to complain and say, I want a, half mad astronaut suit, and I think the virus jumps from dead bodies to other people, and that's why. And so being there, leading by presence and sort of, I think makes it a lot easier to deal with those kind of folks.
One final question. So you mentioned that you selected the medical director to lead the crisis task force. How did you come to that decision? Why did you make that decision?
Yeah, it's a good question. And it was one that came easy and didn't take a long time. And look, my bias is I'm a physician. I'm a physician executive. I view our organization as a healthcare system for older adults. And this pandemic, viral infectious disease, is the #1 issue before the other pandemics that I mentioned that are coexisting is a medical healthcare issue. And I have a lot of confidence and trust in my medical director. It's someone I've trained myself. She was a fellow at Mount Sinai, and it was easy for me. I felt it needed to be a clinician, and also I felt it needed to not be me. And then I had to be careful not to step on her toes and second guess, any of her decisions. We'd rather just talk quietly offline about things if I, felt there was a perspective that would be helpful. And it worked out really well.
Thank you. I'll turn it back to you, Susan.
Well, I think we could go on and on and on. I know there were many more questions, but I want to be respectful of everybody's time. Thank you, Dr. Farber. Thank you, Dr. Everly. Your presentations were spectacular. And to your point, Jeff, even though you did not work together on them, they were very much aligned. And so you kind of were where the rubber meets the road to apply those principles. So thank you both for that. As always, thank you, Dr. Power. Thank you, Eric, from Jewish Home Family. We are always grateful for your comments and your expertise as well. Thank you to all of you who have attended today's session. And next session, 2 weeks from now, September 9, will be on advanced care planning. And we have someone from the Center to Advanced Palliative Care that will be doing the didactic presentation, and a medical director from Jewish Senior Life in Rochester, New York, will be doing the case scenario. So I hope you will register for that one and join us once again. And just a reminder that you will get a recording of today's session and the slides and so forth sent out to you within the next day. So thank you everyone for everything you've done. Thank you for your leadership. Thank you for showing up and really exhibiting the courage, the strength, and the optimism to continue leading. Take care. Be well.
You know,
Bye-bye.
thank you guys.